Much for the thought of the day. Actually, I'm going to hand it over to. Oh, well, I guess what we're going to do now is do introductions. So actually, because Laura is our new chaplain, we're going to go around the table and we're going to just do a quick introduction. So if
Okay.
everyone could take a moment to introduce who you are and your discipline, that would be great.
I'm Andy. I'm the acting medical director.
I'm Callie. I'm a social work intern. Audrey, social work intern.
And of course, I'm Carnell, who assists as an executive director.
I'm Ramona. I'm the one of the social workers.
Christy, RN case manager.
Okay.
And I'm Laura. I'm the chaplain.
All right. With that being said, everyone, thank you. I'm actually going to excuse myself and hand it over for IDT to begin. Thank you.
Thank you.
All right. Thanks, Carnell. Thank you, everyone.
Alright. Okay, so next on our agenda today is deaths and bereavement. We have had 2 deaths since our last IDT. So we had Miss Martha Wilmington. She passed on March 9th. And we are admitting her daughter, Donna, to the bereavement program for follow-up. Donna was in a pretty good place with regard to her coping with her mom's decline, and she was very accepting of the changes that were going on, seemed to be very realistic and what she needed to do with as far as end of life planning. She's got pretty good support as well. So prior to Ms. Wilmington passing, we had assessed her at low risk for bereavement. And I attended the death with Donna. She was present. She is who found her mom. And she was grieving appropriately at that time. She was, very accepting that she's very grounded in her faith and realizes that, her mom's in a better place and is no longer suffering. So I think she continues to be at low risk for bereavement complications. Did anyone else have anything to add? Okay. So we're just doing a standard bereavement follow-up for her, and we will be making the 24-hour call today. And we'll be passing around the bereavement card for everyone to sign. And then our second patient who passed was Mr. Thomas Milford. He passed on March 2nd, and we have admitted his spouse, Rhonda, to the bereavement program. Did anyone else have strong interactions with her?
Yeah, I mean, Christy,
Oh, yeah.
we were there. So, I mean, Rhonda was pretty distraught. It happened really quickly. The other social worker on our team had just left the house, and then we got a call that he kind of drank some Coke and took his last breath. So when we went over there were about 15 or 20 people that showed up at the house. So it was a little chaotic for a little bit. I mean, Rhonda, I think before we were kind of assessing her for high just because of the quick time that he was on service with us. And she just was having a difficult time, I think, with her anticipatory grief. And so, I mean, our assessment, I think, was that she would still be at a high.
I agree. She
Yeah.
was very distraught for him to go like that. As quick as he went, she wasn't really prepared, I don't think. So I think high is a good assessment.
I only saw her for, it's been a brief interaction with her, but I think I would agree with that too. They were very connected emotionally. They had been married for 22 years, called each other their soulmates, and just had that very strong connection. And she's also losing that constant companionship that she had. So I would agree with you all on starting her at a high risk follow-up. So what we will do for that is weekly phone calls out to her and just continuing to check in, and reassess her, how she's coping.
That sounds like a good plan.
Next is our live discharges, and that would be Ms. Deborah Jones. And the anticipated date of discharge is 3/15. We'll be reviewing the face-to-face visit conducted by the case manager. We will be doing the team discussion to make sure that she is appropriate for discharge, and do we all agree that discharge is an acceptable thing at this point in time? And if the discharge is agreed upon amongst the team, we'll make sure that proper notification of the family occurs on a multidisciplinary level to make sure that services and needs are met after hospice leaves the case, and for follow-up should there need to be any, and we'll bridge her should she become appropriate again. And we'll also make sure that the form gets signed that she returns back to her Medicaid or Medicare. Non-coverage form needs to be filled out.
Well, my assessment yesterday at my visit would be that she is reported some signs of, or some symptoms of chest pain and shortness of breath the day before, but it's not a continued thing from her report. She also has gained weight. Her LMAC decreased by 2 centimeters, I believe, but she is gaining weight. And she has become more social versus when we first admitted her. She was very non-communicative, and to the point where we actually admitted her with senile dementia, and now that the diagnosis does not seem to be accurate. So it's a few things that we would need to look at, but at this point, after shooting it up to our clinical team, they do not believe that she is currently meeting the criteria for hospice services.
Does social work or social work?
Yeah, I agree with that too. She is much more alert and communicative than she had been when we first admitted her to hospice. And I agree with you, your nursing assessment, that her presentation doesn't match the diagnosis of senile dementia anymore, not to a hospice degree. So I am in agreement with discharge at this time. And I will be coordinating with her sister, who is power of attorney, to get that Medicare non-coverage form signed. And we've had several talks in the past about how Ms. Jones may not recertify for hospice, so she's already aware of it. And she agrees too that her sister is doing much better than she expected her to be at this point. So,
Ms. Chaplin, do you, upon your visits, do you agree that she is much improved?
Yes, I've only seen her, I think 3 or 4 times actually, but I mean, even the first few times I saw her, maybe the first time I saw her, she was very non-communicative, but then in the last few weeks, I mean, she's talking to me more, she's asking me more questions, so I would definitely agree she's a lot more alert and communicative than when I first met her, even in the last month. So.
Wonderful. The sister, apparently, as I've heard, agrees that she is not hospice appropriate anymore.
yeah.
And the facility also agrees she's not hospice appropriate anymore, so we'll set up our end date for discharge, and we will take care of that, and then make sure that equipment is swapped out said day, and the facility will assume responsibility of equipment.
Sounds like fun.
And now any other comments?
I mean, I see the patient weekly, and had a conversation with her about discharge, and she has seen an improvement in her health and believes she even is appropriate for discharge. Her opinion is, about discharges that she will be disappointed to lose the relationships with hospice staff. So I think that will be the hard part for the patient. So just knowing that as we.
We also want to reassure her that using the bridge program that we have here, that she will maintain some form of contact with us.
Yep. And we can always bring her back on if she
Visualize.
meets,
Appropriate,
yeah,
yeah.
if she meets
Becomes appropriate.
criteria.
Yeah.
Cool.
We'll go ahead and we'll move on to admits. The first one is Miss Jenny Green, and she was admitted on 2/28/17. We have a listed diagnosis to review of Alzheimer's disease with late onset, and the case manager's already done the CL summary, which describes the criteria of why we can admit her, along with other criteria there. So, Ms. Christie, if you want to.
Sure, I'll just read the summary. We have a 85-year-old female diagnosed with Alzheimer's in 2007, treated with Aricept times 10 years. She developed cardiac side effects and required a pacemaker in 2008. The client has significant decline over the past 6 months. Her last known weight was 157 pounds, and her clothes fit appropriately. Significant decrease in intake and subsequent weight loss has occurred. Her clothes are loose fitting, and she's unable to stand on the scale to obtain a weight. Her LMAC was obtained today. I believe that was 27 centimeters. She can feed herself with finger food, but is unable to use utensils. She does not know any family members except her husband and has begun to forget him at times as well. She speaks in short sentences at times, nonsensical speech at times. She has been displaying aggressive behaviors when she's frustrated, and she strikes her caregivers. She has a new prescription for Seroquel at bedtime and Parin for agitation. Her FAST score is 7C, her KPS is 40. Her primary caregiver is her husband, Bernard Green. Multiple generational household and multiple generations are in the household, and also the patient's daughter. Monica Green is also prominent paid in the patient's care and serves service coordination, I'm tongue-tied today. The patient resides in her private residence in Glen Ellen, a few miles from here.
So based on her history, we know that she qualifies because she's a 7C and her FAST score is a 40. And we know that is very rapidly declining based on the assessment. She will meet criteria just based on the FAST score. So based on the assessment, we're going to go ahead and we'll review the medications
Sure.
of what's appropriate and what's covered and non-covered.
She actually is currently only taking the Seroquel at night.
Which is covered.
Yeah, she's unable to swallow pills at this time, so her daughter has requested us to discontinue all meds except for her comfort medications and that Seroquel that she can crush up and put in pudding.
So all meds remain appropriate, because that's their comfort pack and the Seroquel. And now we'll go on to psychosocial report and concerns based on the decline and such.
Yeah, so as it was mentioned in the nursing report as well, the patient has been combative with her husband and other caregivers. Additional stressors include the fact that she was recently relocated to a new home. She's now living within that multi-generational home setting with her daughter and son-in-law, as well as the patient and her husband who will be living there. So a lot of different folks in the household, which is, on one hand good for the support, but it is an adjustment for the family. Overall, her disease is progressing rapidly, as we discussed. So I think, the family are just trying to cope with the changes that they're seeing on an almost daily basis. So definitely adjusting to the new environment, change in status, and this recent
admission to hospice, and decision that the patient needs hospice.